We are ready.
Okay, so I'll go through an overview of the congenital adrenal hyperplasia and a little bit on adrenal insufficiency. Let's move on. So this will be what we are going through. By definition, congenital adrenal hyperplasia is a group of diseases that arise from the inability to synthesize cortisol with excess production of androgens, mineralocorticoids, or both. It's an autosomal recessive disease with several genes that affect different enzymes that we are going to see shortly. The commonest is 21-hydroxylase deficiency that accounts for about 95% of the patients you see. But the others would include 11-beta-hydroxylase, 17-alpha, and 17-20-lyase, and 3-beta-HSD. So this is the anatomy of the adrenal gland. There's pea-sized glands above the kidneys in adults. Of course, in children, they are smaller. And if you cut through them, you'll see that they have a medulla and a cortex. And the cortex will have the 3 layers. And from these 3 layers, we can see the hormones that are synthesized. So the outermost will be the one that synthesizes mineralocorticoids. The middle synthesizes glucocorticoid, which is cortisol. And the one that is next to the medulla synthesizes androgens. Next. So the control of the secretion of the function of the adrenal glands, that is, all the 3 layers are controlled by ACTH. So we have the CRF from the brain.
Sorry, Dr. Michael, the background is a bit noisy. Hello?
So the 3 zones are actually controlled by ACTH. So the corticotropin releasing factor from the hypothalamus stimulates the pituitary to secrete ACTH, which is adrenocorticotropin hormone. And that's the one that stimulates the adrenal gland to make cortisol. And cortisol does negative feedback both to the pituitary and the hypothalamus. What you notice in this diagram is that the other hormones, the mineralocorticoids and the androgens, although all are stimulated by ACTH, do not have a feedback mechanism. And that's why in CAH, if you be unable to synthesize cortisol, then there will be less of the negative feedback, and the pituitary and hypothalamus will note that as a deficiency of the function of adrenal gland, and therefore increase the synthesis of ACTH that will stimulate the adrenal gland. And that becomes vicious because as long as you're not getting enough cortisol, that system will be driven, and therefore you get excess of the hormones, the mineralocorticoids and the androgens. And this is the pathway that shows us the hormones that are secreted. On the extreme right, you can see aldosterone, which is the mineralocorticoid, cortisol, which is the glucocorticoid, and androstenedione, testosterone, which are the androgens. Of course, testosterone is the one that is turned into estrogen outside the adrenal gland. And the hormones then that are affected, the commonest we say is 21-alpha hydroxylase, which is the hormone that turns progesterone into deoxycortisterone and 17-hydroxyprogesterone into 11-deoxycortisone. And that is the commonest. The others are shown in red. And so you realize that in the commonest form of CAH that we have failure to synthesize both cortisol and aldosterone, because that is the function of the 21 alpha hydroxylase. But in the line of androgens, that is not affected. So both DHEAS and androstenedione will still be secreted even when we don't have the function of 21 alpha hydroxylase. And this will come into play as we look at the symptoms. So in terms of epidemiology, we don't have a lot of data from our region. At KNH, we've had 2 studies. One was looking at the cases we see in our clinic, and for those patients who came with DSD, disorders of sexual differentiation, 11% had CAH. And for the cases with adrenal insufficiency, 50% were contributed by CAH.
Dr. Paul, we proceed or
You
I
can
go back?
see one in 30.
Hello, Dr. Lekon, we can't hear you. Maybe
Yeah, somehow I think we went off. I think we are back. So in terms of classification and clinical presentation, the commonest is 21 alpha hydroxylase, which is classified as classic CAH. In classic CAH, you have the deficiency of both severe deficiency of cortisol and aldosterone, and therefore they are salt wasting because of the lack of mineralocorticoid effect. Then you have the simple virilizing, where the only issue you see actually is the effect of the excess of the androgens, and the child is just virilized, but with no, they don't go into salt wasting shock. And then we have the non-classic. Non-classic is the mildest form of CAH, and that would be diagnosed much later in life, either when boys go into precocious puberty, girls may also go into precocious puberty, or they may develop male hair distribution. Some are diagnosed actually as adults, and the females will have what looks like polycystic ovarian syndrome, and those are the non-classic. Yes. Other presentation, especially for females, is ambiguous genitalia. And this would be most of the time realized females. Some males are under-virilized, but that's only in 3-beta HSD, and that is very rare. So whenever you get a child with ambiguous genitalia, like the one shown on this diagram, if you palpate what would look like labia or hypoplastic scrotum, and you don't palpate any gonad there, most likely you'll be dealing with CAH. Next. So the investigations we do for CAH. So once you suspect, the most important to pick is ambiguous genitalia. That would be one of the commonest, especially in females. And when you have such a patient, then it's important to urgently establish whether they have enough cortisol levels or not, because that usually is the emergency. And look at the urea electrolytes and electrolytes, especially because of the mineralocorticoids. You may need an ultrasound to see the internal genitalia, whether they have any Mullerian structures. Then karyotype and 17-hydroxyprogesterone, because the commonest is 21-alpha-hydroxylase, and that's what we'll diagnose. If any patient in the newborn or just after a newborn period comes in presenting vomiting and in shock, other than thinking of our commonest issues of gastroenteritis, think of CAH, and you need to look at cortisol levels and electrolytes. If there is hyperkalemia, hyponatremia, do 17-hydroxyprogesterone. Now, sometimes you find yourself in this and you are unable to do this test. You can collect the samples, and once you've done so, as an emergency, you can start on nitrocortisone. For other places, they will do liquid chromatography with tandem mass spectrometry, and that will diagnose all the forms of ACTH in one test, especially picking the rare forms. Then, of course, you can do genetic testing to establish which particular gene is affected, and that will also give you a very specific diagnosis. Right? In terms of treatment, hydrocortisone is what we use. Remember, we say the disease is a deficiency or inability to secrete cortisol. So hydrocortisone would stabilize, and the way it works is that once you replace the cortisol, you'll also send a feedback mechanism to the pituitary and hypothalamus, and the ACTH levels will go down, and therefore the excess production of either androgens or mineralocorticoids will subside. So hydrocortisone will do 10 to 15 milligrams per meter squared body surface area, and we adjust for 6 days. And we usually give half the dose in the morning, a quarter in the afternoon, and a quarter in the evening. Modified release hydrocortisone or hydrocortisone and mixed with long-acting steroids may be used for the older children, especially when growth has been achieved. For the severe forms, we also use fludrocortisone, which is a mineralocorticoid, and salt supplementation. Usually, these may be required in the salt wasting forms earlier in life. As they grow older, usually the requirement for this is less, and hydrocortisone may suffice. For monitoring 17-hydroxyprogesterone and androstenedione, if you're dealing with 21-hydroxy deficiency, CAH. Also, you need to monitor growth and bone age. In terms of surgical interventions that may be required, would be clitoroplasty for the females that are virilized. Some may require vaginoplasties. For boys, you may need orchidopexy or hypospadias repair. A long time ago, they used to use bilateral adrenalectomy and then supplement the hormones that are not secreted. That is controversial, and not many people do it currently. Follow-up. So on follow-up, we always must look at the growth, because there's a tendency for them to get short stature, and also when you're using steroids, they may cause short stature if you overdose. Puberty, they tend to go into early puberty. They may have hypertension, and they have psychological issues, especially on the gender role. You find a virilized female who may want or feel that they would rather grow up as males. Then they may go into adrenal crisis in terms of stress. They may develop obesity. Now, long-term stimulation with ACTH, of course, they may have gonadal or adrenal rest tumors. Then others develop cataracts and infertility. So these are things that, complications that may arise as you follow up these patients. You need to be aware and take care of them. Locally, we don't know how many patients we have with CAH, especially now we don't have a neonatal screening program. The few clinics that we do follow up for these patients within the regions listed. Hydrocortisone tablets has been available sometimes, sometimes not. It's expensive. Pushing it that it should be one of the essential medications. And this is oral hydrocortisone. Of course, injectable hydrocortisone is fairly reasonably available in almost everywhere in this country. But the tablets are not as available as the injectable ones, and they need to be. Then we look at the sick day management and in adrenal insufficiency. So adrenal insufficiency is insufficient secretion or synthesis of cortisol and mineralocorticoid. And the commonest causes we saw 50% of patients in our clinic is from CAH. A few have Addison's disease, which is primary hypoaldosteronism. Others could be hypopituitarism, and those are the common ones we see. But also prolonged treatment with exogenous steroids may suppress endogenous secretion of hydrocortisone. And that causes a secondary adrenal insufficiency. The history, these patients will come either they are known to have adrenal insufficiency, or if not known, you may have history of fatigue, weight loss, nausea, vomiting, headache, dizziness, confusion. And some may have fever. Potentially fever would be the infection that will trigger the adrenal crisis. As you examine them, you look at the level of consciousness, look at the level of dehydration, look at your vital signs. They are lethargic. Check for pigmentation of the skin, and this is usually caused by ACTH. If there is no, you are not secreting enough cortisol, there is no feedback, then ACTH will be high, and that will cause the hyperpigmentation. Will cause the hyperpigmentation of the skin, especially of the creases and nail beds or scars. Then, if they have a typical genitalia or virilization, then you're suspecting CAH. And those who have neurological changes, especially progressive neurodegeneration, may be having adrenal leukodystrophy. This is a disease that mainly affects the brain, but is associated with various endocrine disorders, including primary adrenal insufficiency. Next. In terms of management, of course, the investigation are the same. Check for blood sugar, check your electrolytes, do a blood gas, identify metabolic acidosis. Look for cortisol and ACTH levels are available, 17-hydroxyprogesterone for those who are not diagnosed yet. You may look for aldosterone levels, plasma renin activity, and in urine, urinary steroid profile, and urinary sodium. In terms of treatment, if they are in a crisis or if they are sick, they cannot take oral hydrocortisone, then you use injectable hydrocortisone. And as I said, injectable hydrocortisone is far much more widely available than the tablets. If they are already known to have adrenal insufficiency, either from CAH or others, minor illnesses, minor emotional stress, you may increase the dose. Just if you're giving 3 doses a day, you may add 1. If they have infections, temperature, some say above 39, we say above 38, you give 3 times the dose you normally give. If they are less than that, you give twice the dose you normally give. So remember, we say 10 to 15 milligrams per meter square body surface area. If you are giving triple, that would be 30. If you're giving double, that would be 20 milligrams per meter square. If they are vomiting, usually you tend to give triple the dose. They are unable to retain orally, do injectable hydrocortisone. Surgery requires preparation, and from pre-op, you need to normalize the cortisol levels before you go to theater. And you may need to give several doses during surgery. Some will give continuous IV infusion. Remember to treat hypoglycemia that arises when you have lack of cortisol. I think that's it. Thank you. Wait for questions or comments.
Thank you so much, Dr. Paul Ligong, for the informative information about CAH. And yes, for our questions, I think we'll do after all the panelists have done their presentation. So thank you so much, Dr. Ligong. On to our next panelist. Our next panelist is none other than Marika. Marika, let me share.
Will you share your screen or shall I try to share my screen?
You will share
You-
yours?
You share the introduction first, maybe?
Yeah, I'm
Yeah,
doing the production first.
Yes, thank you.
Oh, yes. So Marika Medro Mahur, she's a woman living with CAH in Austria, Europe. By profession, she's a nurse and she works in a rehabilitation center. Since 2008, she was involved as a volunteer in the CAH groups. She started in Germany, being part of the German CAH group, which has existed for the last 30 years. In 2016, she founded the CAH Austria, and since 2022, she's part of the founding team of the CAH International. She has received so much help through the people with CAH, through the doctors who support their groups, and she is deeply into the work she's doing. She really loves the work she's doing. She has experienced the power of support groups, and that is why she really loves the work she does. So welcome, Marika.
Thank you so much. So I try to share my screen.
Yes, please.
Yes.
Share your screen. So for Marika, she'll talk about living with CAH in a high-income country and the challenges that she faces. Over to you.
Can you see my screen? Is it?
Yes.
Yes. And you see also it moves on. The next slide. Is the next slide can be seen? Can you see the next slide as well? So that's my first page.
Yes.
Yes. Okay. Good. Yeah. Thank you so much, Riziki. Thank you so much, everybody. Thank you for the invitation. I feel very honored to be part of this webinar. And yeah, I was asked to talk about living with CAH, especially in a high income country, and what are the challenges we are facing as patients, as persons living with CAH in a high income country. Yeah, again, that's me, Marika. My family name, Meyerdorfer-Moore, is not so easy to pronounce. I'm a registered nurse. I work in diabetes care, so I'm quite familiar with chronic conditions, also in my professional background. I do have non-classical CAH myself, and as you mentioned already, Riziki, I'm involved in several CAH groups in Europe, in Austria, Germany, and just some years ago, we started with an international network of CAH groups, and I love this work very much. It's so interesting to network with all the groups in so many countries, to get to know one another, to get to know the problems we face, what do we have in common, and what are the problems because of our different backgrounds, or social backgrounds, financial backgrounds we have. So living with CAH.
Apologies for interrupting you, Marika.
Yeah.
Can you be requesting if you could put your slides on slideshow?
I put it on slideshow. I did.
Oh, okay. From our end, we just see static slides. Can you just attempt to do it again?
Then I try again.
Yes.
What do you see now?
We just see the presentation. Not yet on slideshow. To the bottom right of your screen, They should be next where you see 69%.
Yeah.
Just go click on where you just clicked before. Select this one slide, maybe slide number 2.
You see it now? So on my screens, I can move on, but I can't move on your screen, obviously.
Are you viewing it in a presenter mode?
I
From
am
your
now
end?
in a presenter mode, yes.
Yes, just click duplicate presentation so that we can see whatever you'll be seeing on your end.
There.
Perfect. You can see, yeah.
You'll see it now? You see the
Yeah,
next
now just-
slide now?
Yes.
Yes.
Okay.
Perfect.
So, yeah, okay. Yeah, so the introduction, this is the next slide, and then now I have the slide with living with CAH in a high-income countries. So I will talk about living with CAH, what is it especially to be in a high-income country, and what are the challenges we are facing. So living with CAH, you cannot say that's life with CAH. It's such an individual condition. And I chose those quotes you can see now and those pictures because it shows the variety and the extremes of living with CAH. On one hand, I have this quote. It's from the German, from some German educational material from the German CAH group. And on der brochure, it says in German, CAH, AGS, ist die unschlimmste Krankheit. I hope it translates well into English. It's the unworst disease you can imagine. And this is a quote by a child, of course, but we also have adults who say, okay, living with CAH, I take my pills and that's it. As you can imagine, it's mainly male who say this because for lots of male CAH patients, CAH is not complicated at all. But we also have women who say, okay, living with CAH is not a big thing for me. But on the other side, we have people who suffer very much. I did put a picture, a very old picture, down the quote, below the quote. It's a picture from the 16th century, actually, from a person living on a court, a king's court in Austria. And this is a lady with a long beard and having a small stature. Her name is Gabriela Antonia. And when I saw this painting of this woman, I thought, oh, that might be a woman with CAH, not having a short stature, not having survived without adrenal crisis, growing up. And the quote I put above this picture, they are very strong words, and those words, they touch me very much. They come from a woman I'm in contact actually at the moment with, a lady who said, oh, I'm kind of a monstrosity. I am a miscarriage. And I just had several email exchanges with this woman, and I see for her it's reality. She had to suffer so much in her childhood, didn't have parents who were supportive, didn't have doctors who were supportive. So for her, living with CAH is really a very is a condition with lots of suffering. And we have those two extremes in living with CAH here in Europe, in our countries. And over the years in working with getting to know lots of families with CAH, women with CAH, I saw and I found out all the factors you have, the outcome, quality of life, how you can live with CAH. It depends on so many factors. So if you have early diagnosis, it's so much better with CAH, medication, surgery, availability of high quality surgery for the urogenital. I don't talk about the adrenalectomy. If I talk about surgery, it's about the virilized structures of women. Specialized centers, are there some specialized centers for people with CAH, and very vital, the psychosocial support. So living with CAH in our countries, in our high income countries, we do have early diagnosis in many countries by newborn screening, and this is such a blessing for us. So early diagnosed CAH is so important. It prevents infant death, as you know. So children before newborn screening were dying in the adrenal crisis, in the salt wasting crisis in the beginning, and through newborn screening, it's detected early. Lives are saved through the newborn screening. Then the topic of medication. Is medication available? Yes, as you mentioned now, Dr. Laigong, it's not affordable, it's so expensive. That's what we hear from so many countries through our contacts now in CAH International, that no hydrocortisone available, or it's not affordable. In our high income countries, it's available, it's affordable. We have a social system which helps us so much to get medication for the replacement therapy we need, the hydrocortisone and the fluorocortisone, and also all the medication you need for prevention of adrenal crisis. So we do have the injections, the emergency injections. We do have suppositories in case a child or an adult is vomiting. So we do have those things, and medication in the right amount, taken to the right time, it prevents so much of the side effects you mentioned. Surgery, if you have changes in the urogenital tract, is it available? Can it be made upon an individual decision after discussions between the doctors and the parents? This is what we see, a very important part, but not an easy part. I will say some words after when I talk about the challenges. CAH is a rare disease. Are there some specialized centers? Yes, we do have specialized centers, and this is also such a good thing because rare diseases need to be centered somewhere where they have more patients. And the last point, which really is so important for us, is the psychosocial support. It's the professional help we can get. We do not have professional help everywhere, but in some cases now it's coming more and more. But if I talk about psychosocial support, I also talk about the peer support, so CAH groups, where we help one another, where parents help one another, and also the patient and parent education is part of this psychosocial support. That's what I experienced so much in our CAH groups. I got all this information about the physiology, pathology. I understood then, why do I have to take my medication? Why is it good to take it early in the morning? What is the diurnal rhythm we are facing with our cortisol production? And well-educated patients, well-educated parents, it makes such a difference in the outcome in living with CAH. So living with CAH in a high-income country, you see, we have so many of those factors in our countries. We have newborn screening, we have medication which is available, affordable, we have social system, a very well-developed social system, replacement therapy. But I also put next to some of the points some buts. Yeah, we do have so many of these important factors for a good outcome, for a good life with CAH, but we face our challenges. So I didn't put the point early diagnosis, because in most of our European countries we have early diagnosis, in most countries via newborn screening. We do have the medication also for prevention of adrenal crisis, but still people die in adrenal crisis in our countries. And this is such a sad thing, but still people die, not only with CAH, also with other causes of adrenal insufficiencies. They die because they are not well educated. They don't get the emergency kits prescribed. So we work very much on this. And also paramedics, and in some hospitals, the doctors do not know enough about adrenal crisis. So still in our countries, children or adults die in adrenal crisis. Yes, we have then the next point, surgery. Surgery is available in many countries. We found a very good way, finding the way for the decision whether to perform surgery or not. So not every girl, not each girl has to have surgery, and not all parents ask for surgery. And this is a very challenging topic in our countries. We have lots of discussions. What is the right thing to do in girls with CAH? Are girls with CAH, are they intersex children, or are they girls? How do you define intersex? What does make a person intersex? We have lots of women in our groups who say, I'm not intersex at all. I don't feel intersex. I'm a woman. I have ovaries. I have a uterus. I am fertile. So if you have good treatment with medication, virilization stops, the development, sex development is female sex development. So this is a very challenging discussion we are facing, but we also have people who say, yes, I have CAH, I am intersex. And we have those who say surgery is a human rights violation, and it should not be allowed to be performed on children. And we have those women who say, I'm so glad my parents decided for me to have surgery when I was a child. I grew up in being clear about my gender identity, and I'm so glad they decided it for me. So we live in this very big challenge with these discussions on this topic. And what I find very important is that surgery needs to be accompanied by psychosocial support. So I had a talk to a surgeon and a psychologist from a center in Germany, and they started to have, for each family who comes and asks about surgery, also this psychosocial support. Before, they asked the parents, do you want a psychologist to talk to you and to work with you? And some parents said yes, some parents said no. But now they started to have this as part of the treatment, and they have such good outcomes with this method. And also here in Austria, in Vienna, we have a pet endo and his wife. She's a psychotherapist. They work with the families, and this is such an important thing. What I see in working with women is those women who were left alone with their CAH, also if they had surgery and if the parents and the families did not talk about it, if it was hidden in kind of secrecy and shame, this is so devastating for the soul. And surgery itself is not solving all the topics they have. So it needs to be accompanied if surgery is performed. Yes, specialized centers. We do have specialist centers, mainly in the bigger cities where there is a medical university. So these are the centers where we refer people to, or where we tell them they should go to. But not every patient is treated in a specialized center. I had contact with a woman recently. They live in a rural area in Austria, and the mother thought, oh, it's too far to go to the next bigger city, to the university hospital. I look for a endocrinologist here in my area, and she found one for her daughter. Her daughter is a child, and it was an endocrinologist for adults, mainly treating diabetes and thyroid, but he was quite happy to have an adrenal patient. But it turned out that he was not really specialized on CAH, and this mother came up to me because her daughter gained so much weight and had such high blood pressure with her 12 years. And then I talked to her and said, oh, maybe you should have a second opinion somewhere in a specialized center. Maybe she's taking the medication is too high. So she was on too much fluorocortisone, and yeah, she went to a specialized center, and now it helps. But we do not know, not everybody is maybe treated in specialized centers. And also the psychosocial support has its limitations. Patient and parent education, for example, is not a part of our health system for CAH. I work in diabetes care, and for families who have a child with type 1 diabetes, or also for adults with type 1 or type 2 diabetes, we have so many educational programs. They get educated, they can join seminars. So this is a very well-developed education system here in Austria and in Germany and in our European countries. But for rare diseases like CAH, we do not have this education system. So patient-parent education depends very much on doctors who do it because they see the need, and on peer support groups, CAH groups like we do have. And so not everybody is getting this education they need. And we see it with the numbers of people who have adrenal crisis and do not know what to do. That education is there should be much more education. Peer support also has limitations. Those who come to our group meetings, CAH groups, are most quite well-educated people, who do families, patients whose parents do not have enough education, they just don't turn up in our meetings. So peer support helps very much in growing up with CAH, in living with CAH, but not everybody joins a peer support group or a CAH group as we have it. And the professional help is at its beginning. Here also the psychologists, having psychologists specialized on all the topics on it's the topics of living with a chronic condition, but also the DSD intersex topic needs professionals who have expertise in this part. So we do have our challenges. And if I come back to the slide, from the beginning, I did put a question mark in the middle between those two poles, those two extremes, where the unworst disease versus, yes, I'm a miscarriage, like what this woman said. And what I hope and what I aim, and that's why I am in all this CAH work, we have to move those poles more far. So I think saying it's an unworst disease is not realistic. It's for some it's an unworst disease, but nobody should. It would be such a good thing that nobody would say, "Oh, I feel like being a miscarriage or a monster or whatever." It would be so good if we could all say, or most of us who live with CAH, okay, yes, I have a chronic disease. That's what CAH is, but I can manage it well, and my life is a good life with CAH. So this is what we work on, and we hope we can help in lots of countries to make this come through. So thank you so much for listening.
Thank you so much, Marika, for your presentation. Indeed, early diagnosis, group meetings, and knowledge to the public can play a vital role in managing this condition. So we are very thankful for the information you've given us. Thank you so much. Again, questions will ask later, because we also have another panelist. Her name is Harriet. She's another mother. She resides in Zimbabwe. Let me share. So Dr. Harriet Muhondiwa is the managing partner at GD Consultants. She's the founder of Endocrine Southern African Trust, and she has over 10 years experience from the Cayman Islands and Zimbabwe. She's a mom to 4 children, and she's also a member of the Plan Child Health Africa. We also work together. So welcome, Dr. Muhandiwa. So for Dr. Muhandiwa, she will be touching on living with CAH in a low-income country and the challenges that they face. So over to you, Dr. Muhandiwa.
Thank you very much, Riziki, and it's good to be here. Good afternoon, everyone. And thank you so much for your presentation, Dr. Laigong and Marika. I'll be, adding on to some of the things that you have said already. So I'll just share my screen. Sorry, let me just go over that again. Okay, I think let me just open from here and then I'll just share the screen. Okay.
As Dr. Harriet is opening her file, let me say that Magic Africa also we have a group for CAH and we are forming the clubs. We have parents who really want to connect with other parents because we understand with more information that we are able to share ideas and the resources available to us. So Dr. Harriet, kindly let us know when you're ready.
Okay, okay, let me share this. Can you see my screen?
Yes.
Okay, that's good. Let me put slideshow from the beginning. Can you see that, the screen?
Yes.
Brilliant, brilliant. Sorry for that glitch.
It's okay.
Okay, so yes, I am from Zimbabwe and I am a mom to a 5-year-old who has CAH, a very beautiful.
Apologies once again from our end. We can see a screen being shared, but not a presentation. I don't know whether other panelists can confirm.
Yeah, we are seeing just the file, challenges of living with CAH, but not the actual full.
You're not seeing the actual.
Yes,
All
we're
right.
just seeing the file.
Oh, okay. It's actually showing on my screen. Let me do that again. Share.
It's
That's
okay
perfect.
now.
We can see something, yeah.
You can see. Okay, brilliant. Brilliant. Thank you for that. So yes, I'm a mom to a 5-year-old with CAH, and having given birth to her in 2020, there were some challenges that I faced, and which are common to most parents who are in low-income countries. So I'll pick on the first one, which is something that Marika mentioned already, which is newborn screening. So the first challenge, which is delayed or misdiagnosis, first of all, the lack of newborn screening for us in low-income countries, unlike high-income countries, it is actually absent. So I remember even when I gave birth to my child, there was no way of having screened her, and there was no it was difficult to actually tell at that time what the condition was. So I think for us, it's still a common challenge, which is prevalent in low-income countries. And the impact of this is that it delays the diagnosis until children present with severe symptoms, for example, salt wasting crisis in infants, leading to dehydration or ambiguous genitalia in girls. So that's the first challenge that that presented itself, I think, from the get-go. And then secondly, limited awareness among healthcare workers. So the frontline healthcare providers may not be trained to recognize early subtle signs of CAH. So normally what we've noticed is if one goes to one gives birth to a child with CAH, the doctors at the time and the nurses are not really knowledgeable as to what could be wrong with the child. So it's only recently when this knowledge has been introduced to the healthcare practitioners, especially in maternity wards where children are being birthed, and these early signs are very subtle. So they're being informed on how to handle kids with CAH, but this is, I would say this is more visible for girls. And for boys, it's unfortunate that these signs may not be known because girls present with an ambiguous genitalia, but boys, it's not the same. So it's kind of difficult to then say, okay, this boy has CAH. They'll just go out of the hospital without any diagnosis. And these are the things that will eventually come out, maybe when a child is 3, 4, 5 years old, or maybe sometimes at puberty. We understand that sometimes at puberty, this is when some of the signs start to show. So it's unfortunate that because of the screening and the lack of awareness, it becomes a challenge for this diagnosis to be done. And then another thing is misdiagnosis itself. So the ambiguous genitalia in females with CAH often leads to incorrect gender assignment, and this has severe psychosocial consequences. I've realized, and I've seen, and communicating with the CAH community, they have also relayed to me that when they were in the hospital the first day, it was difficult to tell what gender the child was. So they would even have, discussions with doctors to say, okay, what gender are we assigning to the child, and all that. But I think this is more common in the rural areas because of the remote, of how remote these areas are. It's difficult for them to be in contact with people who would probably sit with them and tell them that, okay, this is CAH and the child is born a girl, so this is most likely a girl. And even after all the scans are taken to see the ovaries and all that, it's unfortunate that in the rural areas, this is not really available. But I think these are some of the things that we face in terms of misdiagnosis. And I remember one surgeon who we had the last time, he mentioned, and he gave comfort to the CAH community here in Zimbabwe. And he mentioned that if a girl is born with CAH, it's a girl, and that's what it is. And we should stick to that. So it was really comforting because all the girls who are females born with an ambiguous genitalia are growing up as girls. And it's a brilliant thing to pass on to my community, to those in the remote areas, those who don't even know about, CAH, because it's rare. And also high mortality is something that is a challenge as well. So late diagnosis of salt wasting CAH is associated with significant neonatal morbidity and mortality. So this comes also with the fact that there's delayed or missed diagnosis. So sometimes a child may be diagnosed as CAH without confirmation that this is salt wasting CAH. So that in itself presents a significant challenge here in our countries, because I remember even for myself, it was later on that my child was, I think she was now 3 years, when it was relayed to us that she is a salt waster. So, so this is some of the challenges that we currently face. And the second challenge, I'll move on to the second one, is inadequate access to essential medication. So this one is a very, heartbreaking challenge, because I believe, and we know, that it's essential for every child to have access to essential medication, no matter their condition. So the first thing is that the availability of hydrocortisone and fludrocortisone is often poor and erratic. So you find that sometimes the pharmacies that you're used to going to that are reasonably priced, and by reasonably priced, I mean maybe $5 difference from the normal cost, because right now fludro and hydrocortisone combined for a month is like $70. So where you normally buy it for $65, it's not there. So you'd have to go and buy somewhere where it costs $70. And these are low income parents. They receive very low salaries, to say. So hydrocortisone and fludrocortisone themselves are not included in the National Essential Medicines list, and the cost is significant, which is a burden for families. And most families that are affected, they're not on any medical aid, and as a result, a family needs, like I mentioned, $70 per month to buy both fludrocortisone and hydrocortisone. So you find that some of the parents can go for a month or two without hydrocortisone, and then they'll call and say, I don't have this medication, I haven't had it for a few months. And then that's when we chip in as Endocrine Trust, because this is the organization that caters for CAH families. So this is where we then pitch in, and we are saying, okay, let's just find means and ways of from our pockets to pay for their medicine. And then the injectable hydrocortisone, which is crucial for emergencies. So many people do not know about it, I should say, especially in the remote areas. And access to this injectable hydrocortisone can be particularly limited. So even the hydrocortisone and fludrocortisone, you find in the rural areas, someone will call and say, I couldn't find it in the area. So they have to travel kilometers, maybe 60 to 80 kilometers to the nearest place to buy the medication. So that is actually a big challenge for us. And then the third challenge, lack of comprehensive and specialized care. So firstly, it's scarcity of specialists. So there are very few pediatric endocrinologists or specialized healthcare teams for us. So first of all, we have very few endocrinologists. Currently, we have one. And in Zimbabwe, I think we have one pediatric endocrinologist. And then we do have surgeons here, but they do surgery for other things and not really specialized in CAH. So you find that if you want a surgeon, you just go to any of the surgeons who do surgery, and those are the ones who will conduct surgery on our CAH children. And then we've also got limited monitoring. So most families cannot afford the regular laboratory testing. I know for some, they go twice a year. For example, this is for the 17 OHP electrolytes. So making precise dose adjustments difficult. So this leads to either under-treatment or over-treatment. And this over or under-treatment can lead to the risk of under-treatment leads to the risk of adrenal crisis and continued virilization in females, whilst over-treatment leads to a risk of growth suppression, bone density issues, and all those other things. So that's one of the major challenges we also face, because families already cannot afford to pay for essential medication. And now this monitoring is something that they can, prolong, or say maybe they can get tested after, several years. And then the other thing is the absence of emergency protocols. So families in remote areas and local healthcare workers often lack clear protocols for stress dosing or managing an adrenal crisis. So this is actually a heartthrob, because every time we go to emergency rooms and we're trying to, we go with our kids who have an adrenal crisis, we have to explain to ourselves that, they have to give them the hydrocortisone first before we start any conversation. So this is a challenge because they actually don't understand. And each time you go there, there's a different doctor, a different nurse attending to you. So we try to tell them that this is different. It's a rare condition. So can you just go ahead and do this? But they'll tell you, no, we first have to treat the illness before we give them the hydrocortisone. So this is a bit of a challenge for us, although here we are trying to also engage doctors and put flyers within the hospitals so that they know that when a child comes through with CAH and they have an adrenal crisis, this is how they are managed. So I picked this from Marika, where she mentioned about specialized centers. So it's something I hadn't incorporated. So we do not have specialized centers. So we do have to go to the clinics and hospitals where everybody else is treated. We explain ourselves and all. We have no dedicated centers. What we have is the trusts or the organizations. We do have the Endocrine Southern Africa Trust. And then we also have Child and Youth Care also. Those are the two major organizations that are here, of which we work hand in hand. They deal with other rare conditions as well, but we specialize mainly in CAH and endocrine conditions. And the other challenge, number 4, is sociocultural and psychosocial burdens. So stigmatization and discrimination. So visible symptoms, for example, virilization in girls, short stature, can lead to social stigma. And this is something that is common. I was speaking to one of the moms the other day. She was relaying to me that one of her children needs, she's now 12, she needs surgery, and she hasn't been able to afford the surgery. So it's one of those things that they are now worried about: stigmatization and discrimination. Currently here, you know, our societies are very, you know, they're very, what can I say? They may not take some of these issues or some of these conditions lightly because they do not know, or they're not aware of them. So most people have decided to keep it to themselves and their immediate families, and not tell the, you know, the external people about their children's conditions, because they believe that the children will tell them at a time when they are grown and you know, they're able to face the people who will be asking questions and all those things. That's one of the other challenges we face. So we've been trying to let people know about CAH, you know, starting with the schools themselves, because this is where our children spend most of the time. And so we are trying very much to ensure that society knows, that the immediate, the families that we stay with already know, and this helps the children, you know, be comfortable in their space. I love it when Marika mentioned that, you know, that it makes it easier for the child in terms of their growth, and in terms of, you know, even when they relate with other people. It's something that we are still also working on and trying to make sure that people know about this. And also another issue is gender assignment issues. So incorrect gender assignment at birth. This is mainly due to ambiguous genitalia. It affects the identity and future relationships. So I think for this one, it would take also the doctors to have specialized doctors from other countries to come and engage in conversation around CAH and some of these things in terms of gender assignment at birth. And also, I think it also takes us, the community, in terms of speaking with other parents around gender assignment and what we have experienced for our own children. And also financial strain on families. So beyond medication costs, indirect costs like travel for distance specialist appointments. For example, you know, like I mentioned, somebody in the remote areas has to travel 80 kilometers to get medication. Some have to travel to get surgery, and they might not have money for surgery. And for the bulk of our community, they are low income families also. So you find they might not even have money for fees. So that's what they'll be dealing with. So so traveling and getting access to medication and the financial strain is a huge challenge. There's also limited education and support. So lack of accessible patient education materials in support groups means families may not fully understand the condition, leading to poor adherence and increased anxiety. So these are, we've seen that patient education materials, in as much as we try to have, things like social media, we have websites, we have all these things. The other challenge is the accessibility of these media platforms to the community is not, it's a challenge actually, because they're not on social media. They don't have access to websites because they cannot afford to buy bundles to give them that privilege to have these platforms on their phones. So it's a huge challenge. And also, so what we've tried to do is, well, whatever monies we get when there are, webinars that are important, we buy for them, and, so that they can get this information. But it's not always the case. They live far away, so and dispersed. So handing out some of the material means you have to drive to their houses, or you have to find a common place where you meet them once in a while, so they don't have some of the information in real time. There's also lack of access to data for educational resources on CAH. So this is the Wi-Fi to join webinars, access to WhatsApp, and even websites. So there's also the language barrier. Even if they do have access, most of them may not understand English. So we have to translate that to vernacular, which is the language that they will be able to understand. And the fifth and final challenge is systemic barriers. So this speaks to the first one, weak health systems. So inadequate funding and competing health priorities overshadow rare conditions like CAH. And then there's also geographic isolation. So individuals in rural or remote areas face insurmountable barriers to accessing diagnosis and treatment. And then the lack of data, which is a limited disease registries, make it difficult to assess the true burden of CAH and advocate for resources. As we speak right now, we have in our database around 20-something parents who've registered for their children with CAH. But we know that this is not all of it, because there are those in the remote areas who have not been accounted for, or have not really come out, and some have just decided to maybe hold on to their children, hoping that maybe it would, maybe if it's an ambiguous genitalia, it will disappear. Because I once heard someone once said that, they were hoping it would disappear. So you kind of think, okay, this is what other people are thinking, and it's real, and this is what they're going through. So the data may not be enough as we speak. So, and also policy gaps, the absence of national policies or programs specifically targeting rare endocrine disorders. So those are the challenges, the major challenges that we face as low-income countries, and how we have addressed some of the challenges. So firstly, we advocating for universal newborn screening, because I believe this is where it all begins, to promote cost-effective and feasible screening programs. So we're hoping to collaborate with the other hospitals and get screening. There's screening for other conditions that's been availed, but for CAH is what we are hoping to get. And secondly, improve access to essential medicines. So we're advocating for inclusion on National Essential Medicines list. But as we speak right now, CLAN has been very helpful. We've had some medicine come through, which was very low cost. I mean, and to the patients, it was actually free when it came. So they would get it at a central place in a hospital where they would all go there and get the medication for free. And this was really helpful. So we're also trying to find ways now, because the medicine finished, and we're trying to find other ways to try and make sure that we continue having medication that doesn't run out. And secondly, strengthening healthcare capacity. So we're trying to collaborate with doctors to train general practitioners and nurses in early CAH recognition and emergency management. And I must say, this is now at an advanced stage because the doctors themselves have been coming through, and we've been in communication with them, and there's been an improvement in how they handle CAH conditions in some hospitals, not all of them, although this is what we try to make sure goes through to all of them. And number 4, community education and support. So we are trying to raise public awareness to reduce the stigma. And we have things in place to help us ensure that this goes to the public in remote areas. We're trying to reach them through community radios and trying to ensure that wherever the news goes, because they listen to the news, so at least we get access to the broadcasting stations who let them know about CAH, and also establish patient and caregiver support groups. So this we're doing also in terms of WhatsApp groups, and also providing material in vernacular. And we also normally meet once in a while to just get to know each other physically and share our concerns. And lastly, which is one of the things I'm grateful for, and also for the platform that I'm here to speak to, international collaboration. So we partner with global organizations, and I'm grateful for CLAN and CARES Foundation. They've really come through for us, and I must be grateful and give them due or credit for what they have done to help us in terms of the resources that we have, in terms of the information that I now know. Sometimes when I speak to the community, they think I'm a doctor, but I mean, I'm a doctor of business, but not a medical doctor. But it's because of the resources that are being availed to us, to me, by CLAN and CARES Foundation. So lastly, while the challenges are immense, with concerted effort, awareness, and targeted interventions, we can significantly improve the lives of individuals living with congenital adrenal hyperplasia in low-income countries. And we believe, and I believe, that every child, regardless of where they are born, deserves the chance to thrive. And lastly, from my own personal perspective, I must say my child is thriving, very intelligent, no different from any other child. And the school she's at, they love her, and they've been very accommodative. And with that, I would like to thank you very much.
Thank you so much, Harriet. Information, the message you passed, we have learned so much, and we are glad to know that your child is thriving. And it's very important to also for the viewers to understand that early diagnosis is always the key, and also management of this condition. A child can just live as normal as other, just as well as other children, and they can thrive and be the better versions of themselves. So to our last panelist, because we understand all these rare conditions, they do affect the patient in one way or another, especially when they're transitioning to adulthood, let's say in the adolescent. That's where we have the next panelist. She goes by the name of Dr. Hilda. Let me share her. She will talk about the psychological impact of this condition to our patients. So with us, we have Dr. Hilda Muiruri. She's a highly motivated psychologist and a registered nurse with over 20 years of experience. She transitioned from being a nurse to become also a psychologist. And she's been able to build up the nursing background and expand her skill setup to provide the mental health support and counseling to individuals and families facing various challenges. Dr. Hilda, I hope you're ready.
Good evening. Hello.
Hello, good evening.
Lizzie.
Let me share with you your work. Sorry, I just saw your message. Adrenal chloride. There you go. Over to you, Dr. Hilda Muiru.
Good evening.
Good evening.
You cannot hear me?
Yes, we can hear you.
Yes. My name is Hilda Muirore. I'm a nurse. I'm a critical care nurse. I'm a counseling psychologist. And I'm glad to be with you here because as we present the CAH, I think the psychological implications cannot be overlooked. I work in Kenyatta National Hospital at the mental health department, and at least we've been able to meet with a few of these cases. And from our end, I can't say that the cases are so many, but still we have a few cases that have been able to reach our end. And that's why I'm talking about the psychological implications of CAH. And I'll just have a brief overview of CAH. And I want to say that congenital adrenal hyperplasia, it's a group of conditions that affect the adrenal glands, causing them to produce excessive amounts of androgens, a male sex hormone, and it's therefore common in 46 XX karyotypes. And this causes them to have ambiguous genitalia, and this is the reason why they land in our mental health department because of the implications that we have to deal with for the same case where, for example, a female child or a female young man or girl is presenting with both or with an ambiguous genitalia. Next. Disorders of sexual development, that is DSD, and especially with the CAH, are doubly challenging compared to other childhood disorders because we find that this is a rare or a unique condition, unlike other childhood disorders. And again, for the other childhood disorders, the parents are aware of what is happening because these are issues that are common and they have seen them even in other children. Unlike in the cases of CAH and our children with disorders in sexual development, which we refer to as DSD. In addition to medical complications, they are also perceived as highly stigmatizing, alienating, and as other speakers have said, there's a lot of stigma and discrimination as parents try to bring up these children, whether from the areas where they live or from the schools where these children attend. And that's why we need to support them as much as we can as they continue to go through the medication of the CAH. And medication and assessments themselves also are very distressing. And we find that, like in our setup, we are in a developing country. You find that the parents are not able to afford even money for the investigations. There are so many investigations that have to be done related either to the endocrinology doctors, the gynae and the surgical doctors. There are so many investigations that have to be carried out, and you find that most of our clients at times give up because they have no money. Sometimes they abscond because they do not even know what they are dealing with. And of course, we have the issues of cultural issues that make them to keep off, so that they don't have to really admit that there's an issue they are dealing with, because they are not even able to explain to the community, even their immediate relatives. They are not able to explain what is happening to their children. So medical assessments themselves are distressing, not only to the patient, but also to the family itself. We can move on. The diagnosis itself is traumatizing to the parents. And we also have the added responsibility of assigning gender at birth. One of the panelists has talked about assigning gender at birth, and you find that, like in our cultural setups, the child is normally assigned gender at birth. And sometimes you find that there are those women who even deliver at home in a way that they never even went landed in any hospital for delivery. So when this child is birthed, the mother will look at the child and probably decide this should be a girl or this should be a boy. So the decision making becomes very difficult. And for example, a parent may decide to assign a boy a girl gender and start bringing up this child as a girl, and dressing the child as a girl, and they can take a very long time before even visiting a medical institution to find out what is happening, regardless of what they can see or whatever else they may be thinking about in the issue of the ambiguous genitalia. There is also a lot of denial. So sometimes they also want to see what they want to see and ignore whatever else they do not want to cope up with. Having to come to terms with children's behavior and play, which may not conform to the assigned or traditional gender laws. And raising a child with a CAH, or we commonly term them as DSD cases, because as few as they are, we deal with the DSD, can turn out to be a big problem, and it requires a lot of support from our side so that these children and also the parents are able to cope with the issues that arise with the CAH and the diagnosis thereof. Next slide. And we are going to look at the psychotherapy for CAH. And I want to say that psychotherapy is key in support for the individual families affected, and it addresses the psychological, emotional, social needs related to the overall well-being of the client. Psychological needs are necessary, and as we address the psychological issues, we help them to adapt to their conditions. We help them to develop self-esteem, because most of them have lost their self-esteem, and especially for the adolescents and the older children, in order to help them process the challenges. And we also help them to develop coping mechanisms for their diagnosis. Counseling also provides a safe space to process their fears. You find that they have a lot of fears, and especially when we deal with the adolescents, they go through a lot, especially in their secondary school for the adolescents. And we find that in our boarding schools, even how the students stay in the dormitories, it's very challenging for them, stigmatizing. They don't know how to go to the open bathrooms and take bath with the rest. And therefore, we really need to start with them, support them, and give them a safe space. But I like the way some parents, as they go to these secondary schools and explain for those who are open, they are teachers who are really able to understand and support our boarding school children. And there is, for example, a case that was given to me that the teacher was able to give them their own private room where they can take bath on their own. And as if that was not enough, though he was also able to make this particular child or student a prefect, so that when he becomes a prefect, he has more authority and cannot be harassed or questioned by the rest. And I thought that was very good support from that side for that teacher who was able to understand and do that for this particular patient. Next slide. Individuals are helped to explore issues like gender identity, body image, and develop a positive concept. We find that, for example, what I'm talking about when the parents bring up a child as a girl and later realize that the problem comes when these children are small, they have to be given an opportunity to reach adolescence where the doctor is able to see the adolescence manifestation of their female reproductive organs or adolescence in a way that they may bring up the child as a female, and then when the child reaches adolescence, they break their voice. So this is where we get crisis, and we have issues like gender identity, and at times we also have to establish which gender to give these children, that is gender assignment. So they are helped to explore their issues and know the way forward. This also helps them to cope with their emotional impact of infertility and stroke, I may say infertility or reduced fertility as it may be. Next slide. The types of psychotherapies that we use are cognitive behavior therapy, which we refer to as CBT. And with CBT, we are able to identify the negative thoughts and distortions. We are able to challenge the same and also distorted thought patterns and behaviors, and all these contribute to their mental health issues. So we are able to challenge the negative thoughts. We help them develop coping mechanisms for stress. We are able to address anxiety, depression, body image, and other concerns related to DSD. And with this, we are able to give them a deeper understanding of self as they deal with stigma and discrimination. We also have psychodynamic therapy, and here we explore unconscious thoughts and feelings that affect a person. It gives a deeper understanding of feelings and helps one to develop a healthier coping mechanism. Next. Number 3, we cannot ignore the family therapy. Family therapy is very crucial in helping families understand and cope with the challenges of DSD and the children involved. And it also helps them to improve communication, build stronger bonds with their families, and the patients are also able to build trust as they grow up. We have humanistic therapy, and this approach focuses on personal growth of the individual. They are able to develop to acquire self-actualization as they continue to grow. And the previous presenter was talking of a child who is doing well, bright, intelligent in school, and they can only arrive at that when they have good support from the various places and the institutes that are able to support them. We also help them to find meaning in life, which can be variable for individuals with DSD as they explore their identity and find or establish their purpose in life. Next. We have interpersonal psychotherapy, and interpersonal psychotherapy focuses on interpersonal relationships, impact on mental well-being of the patient, helps the relation difficulties and challenges related to social interactions, both in school and even in the environment where they live. We find that it's not easy for them to establish themselves from the environment where they live and also back to school. because even as they live at their neighborhoods, there are parents who will hide them and they don't want their neighbors to know what their children are going through. And we find that later on in life, even as they get gender assignments where they have to change the children have to change their genders. For example, one was a boy and now the gender assigned ends up being a male child. If they are still children in school, at times you are forced even to move from the location where you live, and not to mention the school where the child goes. They might end up even changing the schools in order for these children to be able to cope with their environment. So it helps them to be able to deal with these difficulties and challenges as they socially interact with others. We also have dialectical behavior therapy, and it's a specific type of cognitive behavior therapy that emphasizes on emotional regulation. They are able to deal with their distress, and they are taught on how to have distress tolerance. They are also equipped with interpersonal skills so that they may be able to deal with their emotions and their relational challenges. You can imagine this is a child who has grown with DSD, CAH, and they are now adolescents. They have reached the period where they are supposed to be dating. They don't know whether to date a female or a male partner. And this really brings a lot of challenges as they grow up and try to relate. So these are the issues we are talking about and referring to as relational challenges as they grow up. Next. And finally, we can also look at other considerations in psychotherapy. We have individualized treatments because the issues these children go through are individualized, and how one is going to be treated is different from how another is going to be treated, because these conditions are specific to individuals. And therefore, we also involve multidisciplinary teams, because we have to deal with multidisciplinary approaches. And that's why I talked of teams like the endocrinology team. We have the gynae team, we have the surgical team, we have the mental health team, and so on and so forth, without which we are not going to meet the needs for care for the said patients. We also have to ensure that they understand this is a long-term care. We have to bring up these children from the time they are born, they are young, to adolescent, and even to adulthood. And we have to ensure we attach them even as they grow to the various processes of care and treatment. There is also cultural sensitivity and the belief surrounding CAH or the DSD. And as I was talking of the cultural attachments, you find that because of the many beliefs that are there in our environment, that's why some parents will even choose to hide their children, not discuss even with their closest relatives what is happening, and it becomes a bit tricky for these children to stand up while nobody understands what they are going through apart from their own parents. We also have ethical considerations, confidentiality, informed consent, and we have also to respect autonomy on gender identity, which we have talked about, with non-judgmental approach. And I think it's really becoming a problem currently, and especially with the issues of LGBTQ, where a patient may be misunderstood for others, not understanding that this is a medical condition, and that's why the patients have even to have issues like gender assignments. We have to give them support systems like group therapy. Riziki can do good in this as we continue to help these patients have peer support, to have a supportive environment. They are also able to receive feedbacks and develop coping mechanisms. we find that without group therapy, there are those who will assume it's only them who have this problem, and especially like our setup where the cases are not as many as could be recorded elsewhere. But when they are in a support group, they are able to know that it's not only me who has this problem. They are able to have the sense of belonging and even to find meaning in life, because they are able now to mingle with others, with the peers, with the peer support, with a supportive environment, and this will help them to cope with life and to start as they continue with their medication and care for their CAH or the DSD condition. I think that's part of what we do in psychology as we liaise with other multidisciplinary teams in order to help these patients. And I want to say thank you so much.
Thank you so much, Dr. Hilda. Now you know where you can get hold of us. As you can see, she is a wonderful woman doing wonderful work. So thank you so much for your powerful presentation. And yes, so far we have come towards the end, but I want to welcome in any question, and I must apologize for the time which we have consumed because it has gone beyond. But we can all agree that it's a wonderful and a very powerful, very informative information that was shared. And being the month of June, which is CAH Awareness Month, we try as much to create awareness about these conditions and to create a safe space for patients to relate and to feel welcomed and to feel that they're also part of the family. So with that, I want to welcome any questions any pressing question we can direct to anyone. So there is one. Oh, so for everyone, there's someone saying thank you for a nice presentation. Thank you, everyone. So yeah. Oh, sorry, I forgot to mention. For the CAH patients, we have the CAH medical alert form which we created with the CLAN and the Pediatric Endocrine Society of Kenya. Let me show you. It's something that looks like this. Let me close this file. Let me share again. I hope it can be seen by everyone. Yes. So, like I said, this is a medical alert form for adrenal insufficiency in case the patients have these scenarios during emergency. We formed this with the CLAN and Pediatric Endocrine Society of Kenya, where you put in your details, the name, the date of birth, the diagnosis, the emergency contact, and it's an autofill. It just picks up. And then this one, the patient at school or anywhere that can be able to use it in case of emergency. And then it has all the information that that will help the patient in case of emergency. Yes, and also the information to put in case like a immediate contact person and all that. So with that, I want to thank everyone again for their powerful and outstanding presentation. We are immensely grateful to everyone who was able to create time to join us during this webinar session. So I want to thank everyone. So yes, I want to leave the questions to the panelists. If anyone has, we can direct them to them. So we have one for salt losing CAH. What do you look for in urinalysis? That one I want to direct it to Dr. Laigong. Dr. Are you there?
Yes. So if you suspect salt losing CAH, the test to check is serum electrolytes. If you look for urinalysis, you may not see much unless you do serum sodium, urine sodium, because they'll be losing a lot of sodium in urine. But for diagnosis, you do urea electrolytes, serum electrolytes, that would give you a diagnosis.
I hope you've been answered. Yeah. So the other one is no, everyone is saying thank you. This one now is for KNH. Maybe you can assist them later. They're saying they need CPD points to renew their license. So that one, maybe you can look up to it. You can look into it. So to reach us, you can reach us on our website is www.magicfoundationafrica.org. And also, yeah, you can reach us and we can, in case of anything, we'll be in a position to assist you. And also we are looking for other parents with CAH. We really need to connect and see the way forward we can help each other in this wonderful experience or the journey that the children are going through. So I want to thank everyone once again. Yes, this has been a fruitful webinar, so thank you. And yes, follow our website to learn more about us. Thank you.
Thank you as well to Riziki and her team. We have had a really good discussion around this topic, and we are inviting you once again, the team, to bring more topics like this for us to be able to go through, and you can provide information on those topics. We will be back on Thursday with the nursing series, so stay tuned for that and look out for the notifications on your email addresses. We do apologize for the technical hitches for today, and that is why we have extended this session for up to now. So thank you once again for joining us, and also thank you to our panelists. You are welcome once again to join us on Thursday.
So sorry, I forgot to mention, we'll have another webinar series to talk about newborn screening, which is also a very important topic. Because one of the topics we talked about is we do not have newborn screening, mostly in most African countries. So it will be an interesting topic for you to join. It will be in September. We will share the site the minute we plan everything. So thank you again.